Hi everyone and welcome back to my channel. I'm Sheila G the PAC and this video is going to be all about melanoma skin cancer. Now melanoma is one of the most aggressive forms of skin cancer as it has the potential to metastasize throughout the body. So understanding the risk factors associated with melanoma and how to detect this dangerous form of skin cancer is critical. I will be going over the different types of melanoma, the staging process, as well as prognosis based on the severity. I also ask that you share this video with family and friends so that we spread awareness on this type of skin cancer. For more dermatology content, please like, comment, and subscribe to my channel. Let's get started. Melanoma is the cancer of the melanocytes in the skin, which are the pigment-producing cells. Now, these melanocytes reside in the basal layer of the epidermis, which is the lowermost layer of that epidermis, and they deposit pigment throughout the skin. For clarification, everyone has just about the same amount of melanocytes in the skin, but not everyone produces the same amount of melanin in the skin. So for those with darker skin types, more melanin is produced by those melanocytes in comparison to those with fairer skin types. Melanin is a substance that is meant to protect the skin from UV damage. So with sun exposure, those melanocytes become activated and then they release melanin in the skin to protect it. So because melanin is meant to protect the skin from that UV exposure, those with fairer skin types are more prone to burning and UV damage long term. So we classify skin types and the skin's response to UV exposure based on the Fitzpatrick scale, where the lightest skin type is type 1 and the darkest skin type is type 6. This is important because I'll be referring back to this Fitzpatrick scale throughout the video. Now, melanoma is among the top 5 most common cancers in the United States, and its incidence is actually increasing. Melanoma can also affect the palms, soles, the eyes, the nails, and mucous membranes such as within the mouth and the GI tract. Now, melanomas are slightly more common in men and are more common among those with lighter skin types, such as those with a Fitzpatrick 1 or 2 skin type. But please understand that melanoma can and does affect all skin types and all ethnicities. It's very important to know. Now let's go over the risk factors associated with the development of melanoma. First is UV radiation or sun exposure. There are UVA rays and UVB rays. UVA rays are responsible for aging the skin and in photosensitive reactions because they penetrate the epidermis as well as the dermis. These are the rays that also penetrate glass. UVB rays only make up about 5% of UV radiation, but are responsible for burning the skin. So UVA for aging and UVB for burning. Intense intermittent bursts of sun exposure have actually been found to be more so associated with melanoma than chronic continuous sun exposure over time. That chronic continuous sun exposure has been found to be more so associated with non-melanoma skin cancers such as basal cell carcinoma or squamous cell carcinoma. Again, we see a greater risk of melanoma in those with lighter skin types, such as those with type 1 or type 2 skin. Those with type 1 skin have skin that does not tan but burns in the sun, and that is the skin type most commonly seen in people with red hair, light eyes, and freckles. Next is the presence of moles on the skin. There is a greater risk of developing melanoma in those who have 50 or more typical or atypical moles present on the skin. But I will say the majority of melanomas, about 70% actually, do not come from a mole. They actually arise de novo, which means out of nowhere. Then we have genetic factors involved where high penetrance genes are associated with a greater risk of developing melanoma, and I will include these genes here. But those who have a first-degree relative with a history of melanoma are technically at higher risk. Then finally, we have personal history of melanoma. The chance of getting a second melanoma is between 2 to 10%, and about half of those melanomas are actually found within that first year of the initial melanoma diagnosis. Let's move on to the clinical features of melanoma and what to look out for. An easy way to evaluate the features of melanoma is to follow the ABCDE criteria, where A stands for asymmetry, B for border, C for color, D for diameter, and E for evolution. A melanoma is going to be asymmetric, and that means that if you draw a line down the center of the lesion, the two sides are not going to look the same. The borders are often irregular and you might see areas of notching, which means that when those cancer cells start to spread, it just creates a very uneven border. And it can also be due to areas of regression, which that means the immune system is recognizing the cancer as a big problem and tries to take some of the color away. Now, the color of melanoma tends to be very dark, and you have variation of pigment as well, where you might see some brown, black, blue, red, even gray areas within the lesion. The color is not uniform and is often pretty splotchy. Now, atypical moles in melanoma tend to be greater than 6 millimeters in size. Now, this feature alone is not super high yield, but it is important when you have a suspicious lesion. Then we have to assess the evolution of the lesion, which is how the spot has changed over time. Now, there are different histological types of melanoma. Not to get super detailed, but for simplicity, the main types include superficial spreading melanoma, nodular melanoma, lentigo maligna, and acrolentiginous melanoma. Superficial spreading melanoma is the most common form of melanoma, where those cancerous melanocytes spread horizontally on the skin and then eventually penetrate into the deeper layers of the skin and form a tumor. That spread into the deeper layers of the skin is called the vertical growth phase. Now, nodular melanomas present as a bump on the skin or nodule with atypical features, and these are already in that vertical growth phase as they're forming a tumor. Lentigo maligna melanomas are very superficial melanomas that are slow growing and slow spreading and tend to be more common on sun-exposed areas such as the face in elderly patients. Now, these also may eventually spread into the deeper layers of the skin, but it usually takes years for that to happen. Then we have acrolentiginous melanoma, which is melanoma that affects the palms, the soles, and the nails. Those of Spanish, Latin American, African American, and Asian descent are more likely to develop this type of melanoma. The worst melanoma that I've ever personally diagnosed was a 7-centimeter melanoma on the bottom of the foot. When you see a dermatologist and a melanoma is suspected, a skin biopsy will be taken and sent out to pathology to verify the diagnosis of melanoma and also start the process of staging that melanoma. So in America, melanomas are staged using the TNM system, which stands for tumor, nodes, and metastasis. The T for tumor is going to tell us the thickness of the melanoma or how far it has extended into the skin. We also refer to this as the Breslow depth. The nodes portion of this means whether or not the cancer has spread to nearby lymph nodes, and metastasis means whether or not the cancer has spread to distant organs. So the skin biopsy alone is not going to necessarily complete that staging process. It's really just going to tell us the diagnosis and that tumor thickness or the Breslow depth, how invasive the melanoma is. And based on that number is when we continue on in the staging process if necessary. So staging can be a complicated multi-step process, again, depending on how invasive the melanoma is. Stage 0 means that the melanoma is only confined to the epidermis or that top layer of skin. And we refer to this as melanoma in situ. This is very easy to treat with wide local excision, and the prognosis is excellent. Now, stage 1 melanomas are melanomas that have a thickness up to 2 millimeters, and this may or may not be with ulceration. Now, any melanomas that are 0.8 millimeters or greater are always sent out to have a lymph node biopsy, and that's a biopsy of the nearest draining lymph node to assess for any spread to the lymphatics. Stage 3 melanomas are melanomas that have spread to the nearby lymph nodes, and that can be either one lymph node or multiple lymph nodes. Once we reach the criteria for stage 3 melanomas, stage 4 melanoma has to be ruled out, which is distant spread to other organs, and that's done usually through imaging, PET-CT, and a brain MRI. Treatment for melanoma varies depending on the stage. However, all melanomas need to be removed, and the surgical margins depend on the depth of the tumor. For melanomas that cannot be surgically excised, radiation therapy might be an option. If the melanoma has spread to the lymph nodes, whether it's one lymph node or many lymph nodes, immunotherapies might be initiated, and those lymph nodes are surgically removed. For those who have distant metastasis or spread to other organs, immunotherapies and chemotherapies are available to those who are appropriate candidates. The estimated 5-year survival rate is 99% in those with localized melanoma, 71% in those with regional melanoma in stage 3, and about 32% in those with distant metastasis or spread to other organs. I strongly urge everyone to get their skin routinely checked for skin cancer by a dermatologist, as early detection of melanoma is life-saving. Also, do not forget your sunscreen and your sun protection daily, as this is the best way to prevent skin cancer. If you found this video helpful, please like, comment, and subscribe to my channel, and don't forget to share this video with your family and friends. Again, I'm Sheila G, the PAC. Thank you so much for watching, and I'll see you next time.